Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Supreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Joining us today is the renowned spine surgeon, Dr. Abhay Nene, who has a special interest in the osteoporotic spine. Dr. Nene has treated thousands of patients globally and is actively involved in research and academic training. He is the spine consultant for the Olympic Gold Quest and for the Go Sport Foundation, and currently the Asia Pacific chairman of the AO Spine. Besides treating people's spines, Dr. Abhay Nene has completed over 20 half marathons, cycled some of the toughest routes in the world, and is also a talented musician and part of a rock band called the Flunkies. So, let's get on with strengthening our spine with Dr. Nene. Thank you for joining us today, Dr. Nene.
At the top, I want to introduce Dr. Supreet Patel to you all.
Oh,
Patel, because she's doing something that's extremely incredible. Like, it's been years that we've been, meeting ladies who are around menopause and who had these vague symptoms, and we just kind of put it in a bucket, and we say it'll all pass once you grow through this. But in reality, there's stuff happening there, and someone needs to take ownership of this. And we really didn't have anybody to fall back on, and we would literally just console the women and just let them go. And thank you, Suku, for getting this platform on stage, because I think there's a huge bunch of a population of ladies here who would benefit greatly from what you're doing. I mean, from the time that you've told me what you do, I'm finding at least 2 or 3 people every day who probably will benefit with you in their life.
well, you need an army to do this, and so thank you for being part of the army. So yes. So okay, let's start with some real basics, because a lot of us don't even know what is osteoporosis, what is osteopenia, and what does it mean for us.
So I think the myth is that osteoporosis is deficiency of calcium. It's not the deficiency of calcium. So when I'm going to take a minute on this, but when we grow up, our bone is like a bank, and there's a lot of money coming in and a little being spent. So our savings grow. And that's what happens when we grow. In our growing years, that's up to age 22 or whatever, about then. Then between the time, so new bone is being formed and old bone is being removed. So there's a turnover. And between the, adult life, between say 25 and 50, the money coming in and the money being spent is equal, which means that new bone is coming, old bone is going out. So you're getting better bone all the time, but it's at par, which means that there's no increase in your bone mass. Or there's a very slight increase in your bone mass, let's say. And then after 50 for women, because there's a sudden drop in estrogen, and after 70 for men, because men menopause, that's drop in testosterone happens at about 70. There's a sudden increase in the spend and a stop in the in the investment. So there's no money coming in and money is being spent. So whatever bone bank you were left with is what you got to live off after that time. And so really where you have reached when you retire is what decides how you spend the rest of your life. So osteoporosis is when you are on a negative, which means that you at the time of retirement your funds are less, which means the bone bank is not built enough. So by the time you cross that fateful 50, you are left with weaker bones than normal bones, and then it's only downhill from there. So to define osteoporosis, it's the loss of quality and quantity of bone, not just quantity, but quality and quantity of bone. And it's an irreversible situation. You can't reverse osteoporosis. These are all, and there's another big problem that comes with it, which is not spoken of, and that's sarcopenia. So the muscles go through the exact same process. That's what's osteoporosis.
Wow. And I love the analogy, and it's so easy to understand that, we understand money better than our bones for sure. So that's a very easy way for us to visualize it. So you started off with that it's not a calcium deficiency. And I think most of us kind of get married to the thought, oh, I'm having enough calcium. I'm not going to have osteoporosis. So could you spend some more time on that bit?
Yeah. Thing we hear in the clinic that there are two funny things we hear. I'm going to call it funny, but it's not funny. One is that I'm having calcium and vitamin D, so I can't have osteoporosis. And the other is that I have osteoporosis of my right knee or I have osteoporosis of my shoulder. So second thing first, that osteoporosis is a systemic condition. It affects the entire body or it doesn't affect you. It can't affect one area of the body. And so think of the bone as a factory, or the body as a factory that's producing bone. So a factory needs raw materials, the factory needs to be performing, and then the factory needs a demand in the market to produce the goods. So the raw materials are calcium, vitamin D, protein, vitamin C, nowadays magnesium. So there's some raw materials that we know, that we don't know. So they need to reach the factory. With these there, the factory still needs to work and it needs to produce. And osteoporosis is a stop in production of this. So even if you have that raw material sitting in your go down, your factory is not producing that bone when you have osteoporosis. And then if you have both the things working, which means you've medicated yourself, started the factory again, if there's no demand outside, and that's what we allude to when we talk about exercise, if there's no demand from the body, there's no production. So this entire cycle has to be completed. So merely having calcium does not ensure that you will treat your osteoporosis once it sets in. Of course, when your factory is working, which is before menopause, and especially in the younger age, having calcium is one of the good shot in the arms for developing good bones.
Right. And why would you explain why women need to be more careful about it? Are women more hit by osteoporosis as compared to men? Do you think is that what statistics say?
8:2 ratio, unfortunately. But I think one of the key, there are two key factors to it. One is the build. Women are traditionally built smaller, and smaller builds are more prone to osteoporosis. And the other, of course, is menopause, which strikes at the time when a woman is at her peak mental and physical status. And of course, there are many reasons that menopause happens. So nature has thought about everything. But one of the big side effects of menopause is that you end up having osteoporosis. So women are affected 7:3, I'm going to say.
Wow, that's quite crazy. What would you say, like, is the spine more, you mentioned, oh, I have osteoporosis of the knee, of the shoulder, etc. Which regions are more affected? Are there certain regions which are more affected, or the impact of that more? Yeah.
So the commonest, we'll talk about osteoporotic fractures, okay? The osteoporotic fracture seen in the body is the spine, followed by the wrist, shoulder, and hip. I think these are the four areas which, and if you think about it, all of these are weight bearing areas. Of course, the wrist and shoulder is if you fall, but the hip and spine is weight bearing. So if your building is going, or your house is going bad, the column, which is the weight bearing part of your house, is the one that starts giving way first. That's why the spine gets in the mix the first. And osteoporosis is unfortunately a silent disease. So as physicians, we need to think out of the box and look for symptoms and signs and ask for those, because they are not forthcoming. Right. So answer your question, I would see at least 3 new osteoporotic vertebral fractures every week in my OPD today. So I think that's one of the commonest things. Having said that, my mom and my aunt and everyone have had hip fractures. So that's the other big common problem. The difference between the spine and hip is that hip fractures, good morning surgery. A spine can be treated, and it's always good to have a first warning with the spine. And then if you don't, then you don't treat it, then you deserve a hip fracture.
You mentioned it's silent, like vertebral or spine fractures also, could they just be silent? Could one not know that they fractured their spine?
I didn't get you. Sorry. Again.
Hip fractures are obviously painful. The patient, women will come forth and say, hey, I'm in person will be in agony. What about vertebral or spine fractures? Can they be silent?
Asymptomatic. So, the vertebral bones, unlike the other bones that you think of a fracture like a chalk breaking, the vertebral bone is like a brick when you're young and a cardboard box when you're old. So when you're young, you can't smash a brick unless you really use a sledgehammer. But when you smash it, it bursts. So younger people with more solid bones need a big trauma to get a fracture. And that's like the obvious one, where the bone breaks into pieces and you need to go in and fix everything together. That often happens in falls from heights and, car accidents. But as the bones start to get eaten up from inside or reduce their mass from within, the analogy is of a empty cardboard box. So it doesn't take a lot for it to cave in. Remember, you're loading almost 6 million cycles of loading every day on your spine. So that takes, because every time you're upright, like even when we are sitting and sitting here chilling, we are loading our backs, our legs are chilling, our hands are chilling, but the back is being loaded. So the back gets loaded for 18 hours of the day, except when you're in bed. So the chance of that bone caving in, it's called a compression fracture. So it's a impactation or impaction of the bone rather than a bone shattering, and hence it can happen silently. Sometimes it is painful, but there's no history of trauma, and because all it can take is a bad bout of cough, or your car just running over a speed breaker, or you sitting a bit heavily on your sofa. If your bones are that weak, it just caves in. Sometimes if the person's pain capacity is good, and if the fracture is very subtle, it does go unnoticed, which means very often if you take an x-ray of a 85-year-old lady, you will see multiple wedge compression fractures in the back, and they've happened very subtly over time, like a repetitive stress injury. And you really don't have to worry about it. You have to worry about the fact that there is osteoporosis and treat it. So mostly when you get an osteoporotic vertebral fracture, there's panic in the house, but really it's like to sit them down and to tell them that, look, this is a good way to know that you have osteoporosis. Amongst the many ways, this is the best way, and we'll treat you for this, and the fracture is just incidental.
So considering this will be an incidental finding, and you said osteoporosis is silent, what can we do? Like, if you could tell us, what can we do in our younger years? Not even young, I'm not talking about, let's say, 20, that we'll deal with separately. But let's say I'm a 40-year-old woman. I know I'm going to hit menopause at some point soon. What is it that I can start doing to prevent it, to detect it? I don't want to come to you. That's the point. I do not want to come to you. How do I prevent that?
Yeah. So I think prevention gets harder as you go closer to the fateful 50. But still between 40 and 50, you still have a lot. Like someone just said, MAP just said exercise and weight bearing exercise, 100%. So I think you have to fall back to the entire chain of events. Make sure your raw materials are enough, which means pay close attention to your diet, especially regarding calcium intake, vitamin D intake, protein intake. That's what we know for now. The other is start loading your muscles, because there are two things that happen with the muscles. One is that the muscles, when they're bulky, they give better blood supply to the bone. So the bone tends to develop stronger if your muscles are stronger versus very lean muscles. And the muscles also suffer significantly in osteoporosis. So muscle loss can be preempted by working on weight bearing or resistance exercises independently for the upper body and the lower body. And most people don't think about it that way. They just say, I went for a run, so I've done my workout, but it's not. And then the third is to keep a watch on symptoms, because I would not sit here and advise everyone to go and get a DEXA scan, because it's an relatively overrated test. There's something called, so when you diagnose osteoporosis, there are 10 or 15 criteria, of which one is the DEXA scan. And hence you can't just hang your hat on the DEXA scan, but the DEXA will tell you a number. So it gives you a denominator to go by. There's no other test that gives you a number, and which is why we rely on the DEXA scan as a comparative. But if you've been losing weight, if you've been losing muscle mass, if your sleeves are falling looser, if your appetite is gone down, if your height is going down, if your friends and family are saying that you're slightly stooping these days, if your capacity to work is going down, which means that now you used to work 2 hours at a stretch and feel okay, and now you get more tired. I think these are the subtle signs that you want to first look for. And then there are some obvious sucker traps, like if you've been on steroids, or if you've been anti-epileptics, heavy smokers, huge family history of osteoporosis. In the last 1 year, you hit your toe against the wall and it cracked. These are all subtle signs that you want to ask the patient, because as a person, you're never going to be looking for it. And it's the job of the doctor to be asking this and getting this on the table. And because it's still a good time to treat until menopause happens. So it's never too late, So, I mean, I would implore people to, because it's the next big thing. We call it the future shock, and it's already arrived. I mean, I remember presenting a paper in the 2000s, calling it a future shock. And now literally we are seeing, every week, half a dozen patients with osteoporotic fracture. So it's like it's a big disabling problem at the height of your, of your careers, fitness, life. Like 50 to 70 is when you want to really have a good life, because you've worked hard for it, and it can really pull you down. So I think what you mentioned, the time between 40 and 50, you've got to think of I'm going to say 35 to 50, because you're settled at 35. Can take out time and look at your health, and not only the medical health, which is heart and lung and all that, but even physical health.
Yeah. No, thanks for sharing that. And I think, we kind of get fixed on, like most of us get fixed on the DEXA number. And it's great to know that you have other ways of also looking at it, like to look at the whole picture, not just the DEXA scan. But yeah, the DEXA is like a great one time you get a number and at least you know where the woman stands. So that's something about what women can do. I think like as physicians and as gynecologists, because typically the menopausal woman will come to the gynecologist. Um, you know, what are the say let's stick to non-hormonal. What can physicians do to prevent this from happening? You mentioned that it's up to us to think out of the box and tell women about it because
I,
they may not be symptomatic.
I
Yeah.
counseling would be the key. If you can just, because everyone's intelligent, they just need to be told what are the non-investigative ways to know that you have osteoporosis. So
Mm.
counseling everyone who's beyond 40, I'm going to say, is very very important. I mean, I do it at parties also. It's not to get me business
We've
because my
seen
business
that.
is
We've
not good,
seen that.
but just to make people aware because you're still not missing the bus. So I think the stuff that I told you, have you lost weight? Are you losing muscle? Are you on some crazy diet? That's the other thing that we see very, very commonly. That
Yeah.
people lose weight in a good way, go on a crash diet, but they're not working out. So
Yeah.
you're losing. Actually, when you go on a diet, your muscle is being lost. You lose protein before you lose fat.
Yeah.
Your fat is still there. So, have you lost weight? Have you lost muscle mass? Are your clothes
Yeah.
becoming loose? Are you stooping? Has your height gone down? Has
Yeah.
your the work inertia that's creeping? And if all these things are, asked, then the person gets aware. And I would not hold back doing a DEXA scan, randomly after 40 just once. The thing is that the problem with DEXA is that it's like you said, you can't hang your hat on it. And the others, there's some radiation involved. So you don't want to do a DEXA every 6 months, just, be over careful. But one stop short DEXA, because, your peak bone density, what we call your bank is the fullest when you're 35, they say.
Mm.
So,
Right.
if you're at 35, if your bone bank was already down there, you can already start predicting that, at 50, you're going to be much lower. So,
Right.
not such a bad thing to do a DEXA, but I just want to warn people that that's not the only number you want to go by.
Understood. Understood. Also, I feel like as a gynecologist, HRT or MHT as we call it now, it's been FDA approved for osteoporosis prevention, but not for treatment. And if we can prevent, by starting it early, if we can prevent it from happening altogether, then at least, as you said, osteoporosis is not, you can't reverse it, but at least you may be able to push it down by 10 years for women if they start hormones early enough. So preventing in that sense, like doing a DEXA scan early at 40, and if you know that the bank's already kind of low or at perimenopause, and perhaps we can intervene and stop it from happening for at least a decade,
Yeah,
if not
I
longer.
agree. And but I mean, in a good way, we see a lot of women coming to the clinic with
Mm.
a DEXA. They're completely asymptomatic, but their DEXA is lighting up. And I mean, I'm happy that they did it. At the
Yeah,
same time, definitely don't want to sit here and give a message that everyone should get a DEXA at
got
40
it.
years, because
Got it.
it would be a wrong message. And the big fallacy about the DEXA is that the scores that we pitch your score against are Caucasian numbers.
Uh,
And
uh,
Caucasian numbers are going to be for Caucasian body habitat, bad body sizes. So invariably we are low. We have done a couple of studies, trying to check Indian data with that, and there's a clear 20-30% deficit. So sometimes it just, throws you off on a wild goose chase. So you got to be aware, but you got to look at the big picture.
yeah. Well, why don't we use our data on these machines?
No
Like, will
one
it
has
take time? We don't have
ordered.
numbers.
Mostly, first of all, there's no Indian company that makes a DEXA machine. So they
Mm,
get fed in with, but I think with AI coming into radiology, uh, the more Indians do, the more it's going to calibrate itself better. But
wonderful.
unfortunately, something else called QCT, quantitative CT, which
Okay.
is actually a definitive marker. It's a real number of how strong your bone is.
Mm,
Like it's literally dividing mass by volume. Literally that.
mm.
The problem is that we don't have the normal values. So
Oh,
if you say that okay, I'm 85%, is that a good thing or a bad thing? You're not able to say.
not yet. I guess in a decade,
Yeah.
perhaps,
See,
or
a
sooner.
lot of work is happening across the world because we are not the
Mm,
only two people bothered about this problem.
of course.
The entire world, I mean, it's the number one cause of disability across the globe, especially in the West, where
Mm,
people are living longer and want to live more actively.
mm,
So we have 70-year-olds asking to get surgery done because they want to start skiing.
mm.
So, they are more at risk of injury. And I think all our parents, and they fall in the same category. I mean, our
Right.
grandparents are not as active at 75 and 80 as our parents are. And we'll probably
Right.
be. So if your tin work is falling over and you want to still race your car, then there's a likelihood that you're going to have these bumps and dents.
Understood. What about someone who's already osteoporotic? Like I think sometimes there is a fear that I'm already osteoporotic, I can't exercise because what if I break something? What does one do then?
Yeah. So before that, I just wanted to address what's on the screen. Someone said I have osteoarthritis. That's one common thing that people mix. Osteoarthritis is wear out of the cartilage of your joints. It is completely unrelated to osteoporosis. So just get that clear. And everyone, that this person says I'm 38 or something, but everyone's X-ray will suggest osteoarthritis because as you grow older, there's a wear out. So if I have a shoe that is 5 years old, it's going to look 5 years old. As long as it's working well, you don't have to worry about it. So to answer the question of if you already have osteoporosis, what sort of exercises can you do? So typically, it depends on the status of the osteoporosis. So there are people who are extremely frail and deep into it, like with numbers of -4 and -5 on the DEXA, or maybe with already some symptomatic fracture. There we would kind of hold back and say do what we call isokinetic exercises, which means rubber band type of resistance exercises. So you'll never overdo it. If you're not able to pull beyond this, that much resistance, if you pick up a 5 kilo weight, that weight remains constant no matter how much you're able to do. So the chance of injury, that's called a isometric or isotonic exercise. So rubber band exercises in bed, lying down, so not loading your back. I think those would be the way to go. It gets harder as the osteoporosis gets deeper. And in the physio group, exercise actually physio is contraindicated for people with osteoporosis because at their level, they've had many injuries while dishing out their treatment because they have osteoporosis. But in the middle group, which means that your numbers are not so good, but you're otherwise okay, I think it's perfectly fine to start, doing loaded exercise. Once again, if you're worried, you can do independent workouts. Like you can, isolate. Like what I would warn you against is high impact workouts like jumping, skipping, aerobic, Zumba, if you're osteoporotic, and doing compound workouts where you're working 3 or 4 muscle groups at a time. So you can do isolated biceps, isolated triceps, isolated overheads, but don't take a weighted squat or a weighted deadlift or something like that where multiple bones can get loaded and something may give.
That's only if you're at the other end of the spectrum. Otherwise, you're saying it's okay to do. Someone just said Dr. Nene, the best doctor ever. So I agree with that. Just thought I'd say that. Would you have any advice regarding a couple of people have asked about supplements. Is there something that you routinely advise in your practice to
Calcium is a must.
there?
So let's talk women. So in the growing years, calcium supplement is a must because our diet doesn't provide enough calcium. Like in your growing years, you need about, between 500 and 1,000 milligrams of available calcium, through your growing years. In your middle years, adulthood, except during pregnancy and lactation, where your requirement goes to 1,500 per day, 1,500 milligrams per day, then you don't need if you're not pregnant or not lactating. And post-menopause, again, you need 1,000 per day. And there's no food that can get this, like you need 1 liter of milk a day to get 1,000 milligrams of calcium. So it's impossible to cover it with food. And hence, we blindly ask women to take 1 calcium tablet, which is equal to 500 of elemental. And if it's a calcium citrate malate, it's 250, but it's the same quantity. So 1 calcium supplement rather than 3 or 4 a day, because then it will start giving you the other side of the problems, calcifications, renal stones, etc. And the other is vitamin D, which is again ubiquitously absent in us. And there's a little bit I want to tell you about it because the natural source of vitamin D is sunlight. And even if you go out in the sun, because of our skin color and because of the smog in cities, there's ultraviolet filtration and you don't really get conversion of your subcutaneous vitamin D to its active form. So vitamin D deficiency is an urban disease across the board. So all of us take vitamin D supplements. Approximately 60,000 units a month is a decent rhythm to go with. The third is classic in India because many of us are vegetarians is protein deficiency. And it's interesting to know that you need 1 gram per kilogram body weight of protein, which means that a 75 kilo guy would need 75 grams of proteins a day. And my 1 bowl of dal, which I eat proudly, gives me 4 to 6 grams a day. and one egg would give you about the same. So there's a huge discrepancy in the protein intake in vegetarians. So I mean, I just had my protein shake right now. So whey protein is a good option if you're burning it and if you're doing muscle workouts. Otherwise, it has carbs also. You get low fat and low carb whey protein, and it's made from natural sources. So the word whey protein sometimes triggers a whole chain of thought in people's mind, supplements and artificial and cancer. It's not really true. It's made from whey. Whey is derived from milk. And then there's local protein supplements like sattu, chane ka atta,
Yeah.
which again you can stir and drink, but there you can't do carb free. It is high protein but high carb also. And then nuts and other things. So soy has very very good
Yeah.
high protein. So soy chunks actually has the highest amount of protein per solid per solid weight. And so those would be the three supplements I would want to lean on for everyone across the board.
Wonderful, wonderful. In fact, there was a recent study that proved that we need 1.2 gram per kg body weight to just prevent frailty, only to prevent frailty, not even to be in good health, which is, yeah, if I think none of
Yeah.
us meet it unless we actively look for it. So it's a real effort to make sure that you're getting that much of protein. It's a lot of work, but it's great to have that number. Once it's habit, then at least people can continue with it.
Protein, Suku, is that it starts giving you acidity, gas, everything, because it's not easy to digest. And then people go off it. So one other advice you want to tell all your patients or friends is that you start slowly, like build up slowly, let your gut get used to it, because it's not toxic for you. It is just
Right.
that enough hydration. You can't have protein and not have water, and you need to up it slowly, and you get used to it.
Right, right. Yeah, that's I think great piece of advice. Just go slow with everything. There are a lot of questions about someone had cervical spondylosis, and I hear this very often in practice as well. That oh, I have a prolapsed or slip disc as we call it, and I can't. I've been told not to pick up more than 2 kilo weights or something. And these are like sometimes they're young people, so you can't imagine them never lifting more than 2 or 3 or 4 kilos for the rest of their lives.
So
What is your advice?
veering off
Yeah.
topic, but I'm this is my work and my business, so I'm very passionate about it. That mostly spinal problems are overtreated. Like in the past, anyone with any degenerative pathology, any wear and tear pathology in the back would be put off doing exercises. So there would be a big list of don'ts. But today, the
Mm.
whole game is switched. There's a paradigm shift in the way you treat slip disc, spondylosis, even osteoarthritis for that matter. And there's a whole list of do's that come up. You do these do's and then there's no don'ts, and those do's really work around shifting the load bearing from the worn out spine to the active muscle. Your muscle is the only musculoskeletal tissue in your body that can regenerate till you die. It's a very strong statement, but it's a true statement. So it's the only resource you can hold on to when everything else is falling over. Your joints are
Mm.
going, your bones are going, ligaments are turning lax, everything. But you can still work hard on your muscle. So mostly rehabilitation means realigning the way your spine is going to take loads, which where you have to spend some time, and it's the do's, the exercises, the posture, the supplementation, etc. And then you can get back, and all the don'ts get go out of line. This what I'm saying is true for 95% of people who have been told you've got a slip disc or you've got a spondylosis and you can't do blah 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 blah. 5% are of course outliers where we need to come in, and that's how we get we get our business. But
Mm.
95% really need just good counseling and the fright has to be taken out of them. And just
Mm.
one thing, the link between osteoporosis and this spondylosis, osteoarthritis, slip disc, etc., is that in untreated osteoporosis, no matter how hard you work, you can't get your muscles to perform. So you have one resource available, but you've shut it down because you're not treated your osteoporosis, and that becomes a
Mm.
problem because now you're faced with two situations. You got to deal with one, and then that will help deal with the other, which takes a much longer downtime than it would have taken if you came with treated osteoporosis.
Right. And what about, it sounds kind of counterintuitive, right? Like if you have been told you are not allowed to lift weights or not challenge your muscles, then aren't you in some way aggravating the problem of osteoporosis because now you're further not using a set of muscles. So even if someone does have a prolapse disc, like I think it's great that you're mentioning you can rehabilitate, make sure that you are getting the right set of instructions. Don't look at the do's, the don'ts, look at the do's. So
Yeah.
that's great advice.
If your
What is,
if your
yeah, sorry, go ahead.
if your osteoporosis was more significant, you would prioritize that and work on lifting, keeping your back offloaded. And if your back was the bigger problem, you would prioritize back exercises and keep the treatment of osteoporosis for later.
Wonderful. Wonderful. Basically, do something can be done about it. Just don't think that dukan band can't do anything. That is not the solution. I think that's really important. What about meds which are used for osteoporosis treatment? Very often you hear someone's gone for a monthly injection or a daily tablet of medicines like biphosphonates and things like that, which are supposed to improve your bone density. Yeah.
I'm
What
to
is your take?
oversimplify it for the for the reason of this interview. There are 4 categories in ascending order.
Yeah.
Besides the hormone replacement therapy, which I have no knowledge about, I just know that it's made a comeback, and you've told me about it. But so the pure anti-osteoporotic medicines start with a weekly tablet, which is the bisphosphonates, which is the easiest. The deal about this is that it creates harder but not necessarily better bones, but it's the best available thing at that age. So normally someone in their early 50s who's just noticed osteoporosis, not too deep in the game, we would use this as a supplement if there's no HRT available, and ask them to do exercises, etc. The US FDA permits you to take this continuously for 4 years. The next one on the ladder is the 6 monthly injection, which is a denosumab, and that is does the same as the bisphosphonate. It's a bone loss preventing item, not a new bone forming item, but it does it better, and it's US FDA approved for 10 years. Some of this data is skewed by industry interests, but this is the data that we get, and we right now follow it because the US FDA seems to be above board. The next on the line is the daily self-administered injection, which is teriparatide, and that's like, it was gold dust when it came up, and it can really reverse osteoporosis. It can really form new bone. It comes with 2 caveats. One is that you can only take it for 30 months in your life, and someone who's had a history of bone cancer is can't take it. So because it's not been shown to be absolutely cancer proof. And then the last one is the new drug, rosacizumab, that has come up, and that only one company makes it. We call it Evenity. It's called as Evenity. It's a once a month injection, which is a combination of the teriparatide and the denosumab. So it works as a combination, once a month injection. Currently, it's available for 1 year, but we expect the US FDA to allow it for longer. So these are the 4 drugs in ascending order. But when you think about the numbers that I told you, you have to know that currently we have less than 20 years of treatment available for each one of you, right? So start early, you're going to run out of stocks at 70, and you really need your treatment after 70. And that's where the game gets harder to play. And we normally work around the corners, and we try to stop the drug, give a treatment holiday, again restart. I mean, we don't have a freedom of just continuously giving you medicines till you die. If once that comes in, then it should not be such a big problem. Here we are just ducking the cover and then trying to get across.
Yeah, and I think that brings me back to the fact that prevention is so important with osteoporosis, because we kind of assume, no, there will be meds to treat it, but even if we do treat it with medicines, we are still stuck with time, and our lifespans have increased, but not necessarily our health spans, and we don't want to be immobile for sure. So ladies, let's just prevent it, and rather than suffering from it later on. So that's a great message to take back. What about our youth? What can our children do to prevent it, considering our bone mass is built in younger years? What's the message for our bacha party?
So while a large chunk of this is genetic, which is out of your control, there's a lot of it which has to do with lifestyle. And obviously, eating the right food, doing the right loaded exercises, like going outdoors and playing, teaching them to do cycling, swimming, running, rather than playing just video games. I'm not against video games, but you got to spend enough time physically getting stronger, eating the correct food, assuming correct postures, keeping a watch on your body weight, because thinness and fatness both are things that cause. Then cutting off things like Coke. I'm saying aerated drinks, smoking in your slightly early adult life. I think these are the things that you can do, which is common sense, but it's been so oversaid that kids just run away from it, and it becomes to sell this to to a child who doesn't understand, and at 50 it's too late.
Yeah. Also, then at 20, someone tells me I'm going to get osteoporosis. I just feel like, oh my God, 50 is so far away. So it's also hard to convince a young person, but we can always try. So that's that. What are the takeaway now? I see a few questions, but they're mainly, I think, a lot of questions on arthritis and cervical spondylitis. But I guess they can ask you those questions in the comments, because this is focused mainly on osteoporosis prevention and taking care of our spines. What would be like the three big takeaways that you'd like to tell women specifically, because we are just going to talk about women today?
Yeah. So I think the first is that every woman is going to get osteoporosis. It's just a matter of how soon and how bad. So just be ready for it, and it's never too early to start thinking about it. That's the number one takeaway, unfortunately. The number two is that prevention is better than cure, which means that now, today, start working on yourself, because though we say 50 or menopause is a cutoff, in reality, it's not a switch off. Actually, there's some, it just lazes over, but the curve starts to drop, like that. It doesn't drop like this at all. So it's never too late to work on all the things that we spoke about, which is exercise, raw materials, calcium, vitamin D, proteins, and medication if you need to take for osteoporosis. And the third is, I'm going to say, be vigilant about your parents and do fall prevention, strategies at home. I know this is slightly outside of what we discussed, but invariably it's the 70-year-old who's already way past the red line, who's the, sufferer. So if you have those in your house, don't think that, oh, I've started the medicine for him or her, so he should be fine. And prevent domestic falls by, having your bathroom lit. I mean, the way to the bathroom at night lit up, not having those edges to climb over, not having free carpets, and having some handrail somewhere. So there's a whole bunch of fall prevention things that you can do to avoid fractures in the elderly, which is a very, very disabling problem.
Right. Yeah, wow. That really hit me. Even though you see it every day, the thought that every woman will finally eventually get osteoporosis sounds awful. But I guess the truth is not always sweet. So thank you for pointing that out. Okay, anything else that you'd like to share with us? And I can't see
There was
any
something
questions
about
which just
stone, thyroid, etc. Thyroid has got nothing to do with this problem, so you can safely do everything that we mentioned, even if you have a thyroid issue, as long as it's being well treated. As far as kidney stones are concerned, you should know what type of stone there is, and you can take a calcium that is not bad for that stone. So your urologist can normally tell you. And the other big thing about spondylosis and arthritis, etc., just in a nutshell, I can tell you that spondylosis is again an overused term. It's a wear and tear of your spine, and all are going through it, men and women. Like if you get my X-rays at 52, you're going to see cervical spondylosis, lumbar spondylosis, and knee arthritis. And today I ran 19 kilometers. So it does not mean that you have what is reported on X-ray. And we all get aches and pains. So you don't have to suddenly go over the line. Typically, the treatment of these conditions is to get your posturing appropriately done and get your muscles to work in place of your bones. And a good doctor can counsel you, and you don't need to recurring consults with doctors. Once it sits in, that's all you need to do, which means that if your shoe is old, you use it appropriately, but don't stop using it. I think these questions, that's the other thing I wanted to tell you.
Yeah. Now, I think the concern about thyroid is mainly with soy, because older studies indicated that consumption of large amounts of soy can affect your thyroid function. It can make you more hypothyroid. But over time, there's a huge meta-analysis which has kind of pushed that away. So yes, soy is safe with thyroid disorder, especially because soy is a great source of phytoestrogens for women as well. So that's it's a great source of protein. I think soy is great for women overall. But yes, thank you so much for sharing everything that you have today. It's been such a pleasure to have you, and thank you, and thank you everyone for listening. And we will be posting the full episode for others who couldn't attend.
On the gas, because there's going to be a huge list of beneficiaries that are going to thank you.
Oh, thank you, and you. All right. Okay.
Yeah.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.